Good afternoon. Today is October 28th. My name is Kemal Erkan. This is American Surgery Center Bariatric Program. I am here with Dr. Isaias Irgau. And Dr. Irgau, how are you doing?
I'm doing great, Kemal. Thank you. And great to be back on Bariatric Friday again.
It's always good to have you back. So we are going to continue with our journey with our patients, Patrick, Denise, and Karen. So we are going to discuss life after bariatric. In a different term, perhaps we can say, what can we expect after bariatric surgery? So that is going to be our focus today. So prior to start, Dr. Irgau, if you don't mind just giving us the background on the qualification
Absolutely.
of surgery.
Absolutely. Yeah, hello, everybody. Again, my name is Dr. Irgau. I am the president of CRIAS, or Christiana Institute of Advanced Surgery. My specialty is bariatric surgery or weight loss surgery. And bariatric surgery is currently by far the most effective treatment we have for morbid obesity. And morbid obesity essentially is obesity that has gone extreme, that is very difficult to treat any other way, right? And that is usually when the weight is about 100 pounds higher than the ideal body weight. And that is quantified in the form of body mass index as well. Body mass index is a number that is calculated by putting the height and the weight of the person. And generally, we say that the body mass index of 40 or above qualifies a person for bariatric surgery. But Kemal, I'm actually very, very excited to say today that our society, the American Society of Metabolic and Bariatric Surgery, has just published its recommendations for new criteria for weight loss surgery. In other words, now we know for a fact that even patients with a body mass index of 30 should be eligible for bariatric surgery if they have associated illnesses like type 2 diabetes or high blood pressure.
That's just published today?
That just was published this week. It was published this week, and they are recommending that we offer bariatric surgery to patients who have a body mass index of 35 or above without any comorbidities. So the comorbidities would be required if a patient has a body mass index of 30 to 35, but if a body mass index is 35 or above, we are recommending that we should not require development of illnesses. In other words, we're saying, why do you want to wait until that person develops diabetes or high blood pressure before you offer them this very validated, effective treatment we have, which is bariatric surgery? So our job now is going to become out to make sure that these recommendations are accepted across board, and that insurance companies also do their due diligence in making sure this coverage occurs for people who are otherwise pushed out of the door before, even though they demonstrated they couldn't lose the weight in any other way. And the only way they could qualify for the surgery was for them to continue to gain weight, which is absurd. So we're saying, don't wait for a patient to get to a body mass index of 40. If they've reached 35 and they've struggled to lose weight any other way, you should be able to offer them bariatric surgery.
So that actually is, well, it's interesting in a way that as we are going through our activities to make sure that people are understanding the difficulties and all the issues, all the stigma around the bariatric surgery, yet there's another step now that's actually expanding the patients who may be qualifying for this. So, absolutely. Well, that kind of validates the issue of this is one of the roots of the issues, like other comorbidities. It's not some, like you're not diabetes and now you're going to get morbid obesity. Chances of if you have morbid obesity, you are going to get diabetes or sleep apnea. So I think that makes it makes sense to us.
Absolutely. Absolutely.
But for people to better understand, there's only 1% of the people who are qualified for bariatric surgery is getting bariatric surgery, and this is the most effective way of taking care of this issue. So it's going to make perhaps our efforts a little bit more important now that we can reach out to more people and then hopefully make some changes. Now, as you remember, this is our one of our patients' journal cycles. So then we are with Karen, Patrick, and Denise, and then these guys do have different issues. Patrick was at age 30, Denise is at age 32, Karen is at age 52. And then the BMI levels and all those issues that they have. Now we know that Patrick is someone who has TSH 7, which we did take care of that problem before the surgery because it needs to be under 4.5 before we actually, he worked with the endocrinologists to get that down, and also with our bariatricians. So now for Denise, A1C was 9, and now it's under 7. Which we go with the fructosamine, but her hemoglobin was around 9, a little bit low. Now she's going to repeat that test because she's taking iron supplements. And then Karen, who's going through bypass, also suffering from diabetes. A1C is 11 now, down to 8.
Excellent.
So now, from our patients' point, what can we expect after bariatric surgery, after all the things that we have done? Now, we didn't get the surgery yet, but they're about to get it in the next couple of weeks. So just to prepare them, so what's coming to their way?
So the points that we are going to address, Kemal, are going to be fairly valid for all three of them, whether they're having the sleeve or gastric bypass. And from our conversations before, I remember that Karen is due to have the gastric bypass surgery, whereas Denise and Patrick are both going for the sleeve gastrectomy. So there are going to be some differences in terms of expectation of points to look for. But by and large, most of the issues that we're going to address right now for what to expect after bariatric surgery are really valid for both procedures, okay? Which are, as we mentioned before, the procedures that we do the most in our practice. Of course, we do some gastric banding and we do some gastric balloon procedures as well as the duodenal switch. But in terms of numbers, the vast majority of our patients undergo the gastric sleeve or the gastric bypass. And the main difference, just to remind our viewers, is that with the gastric sleeve, we actually divide the stomach and remove a portion of the stomach. So the surgery is really on the stomach itself. With the gastric bypass, we divide the stomach, but also we reroute the intestine. Those are the two main differences of the procedures. So what to expect? Well, in the short term, right? Let's see what happens in the short term, a day, 2 days, a week, or so after surgery. Obviously, there is the recovery phase, right? And one of the questions that comes up very often is, how much weight pain will I have? Doctor, I did have a C-section and I had, I remember my recovery then. Doctor, I had a gallbladder surgery and I remember my recovery then. What am I going to be, right? So in terms of discomfort, well, I am, it's very clear right now that particularly in centers like ours that have adopted fairly good protocols to control pain, patients actually, that doesn't become a major issue when they are recovering, right? We manage pain not when it occurs, but preemptively. We utilize different methods really to minimize the reception of pain by the body, so much so that, as you can see them in our center, Kemal, within hours of the surgery, our patients are walking around our center, right, with their nurses. And we expect them to do that at home as well. So the vast majority of our patients will say that maybe they've taken pain medications for a day or 2 days, but no more than that. So pain as such, particularly because the procedure is done laparoscopically with small incisions, is not a major issue. And the other issue that we've really been able to control well is nausea and vomiting. This used to be something that we saw a lot, 15, 20 years ago, but with the way we're preparing patients for surgery, nausea and vomiting are not really common things that we see at all. We do send patients with some anti-nausea medications just in case, but that is not a major issue at all, right? So their recovery in terms of surgery and then the expectations after surgery, whether pain or nausea or vomiting, are not major issues for our patients, I'm very happy to say, right? And then the other issue is, how about diet? How do they progress through that diet? What should they expect? Well, there is actually a very clear guideline of what to do with diet after surgery. For instance, we want our patients to be on what we call a liquid diet for the first 2 weeks after surgery, right? After the first 2 weeks, they will be progressing to what we call a puree diet. And the best analogy for puree diet, Kemal, is baby food, right? Baby food is of such softness that we give it to them because they don't have any teeth. They don't know how to chew, right? And our patients have to assume as if they have no teeth at that time. So that food has to be soft. And it's only after the 4th week, after the 1st month, that our patients are encouraged to introduce chewable food. So in terms of diet, this is going to be their expectation. And patients very often ask me, but why do we have to do that? Why can I not, if I feel I want to munch something, why can I not do it in the 2nd week? Actually, this is something very important for patients to understand. It's actually dangerous for them to try to chew something so early after surgery. And that is because the wound on the stomach or the intestine is so fresh that if they inadvertently were to swallow something without chewing it, they will have a big chunk of food there that could put pressure on the stomach and put them in danger of leakage or disruption of that wound of the stomach. So it is very important for our patients to follow those instructions when it comes to diet progression. So liquid diet for 2 weeks, puree diet, and then solid food afterwards. There are some important issues that I need to expect, at least in the early weeks after surgery, Kemal, and that is most patients will experience in the change of how they smell food or how they smell of food. So much so that things that they loved before surgery, they may not care for afterwards, or things that they didn't like after surgery may be more appealing for them. These are related to the fact that our digestive system is a very well integrated system, that when we make such drastic changes to the stomach, it affects our taste organs as well. Okay, so patients need to figure out what it is that they like and what it is that they don't like. And very often they will not like to be exposed to very strong smells, foods that have very, very strong smell. They may not like it at that time. It may elicit nausea. And I do counsel patients after that. Now, swallowing also by itself is going to be different, right? Before surgery, they may not be aware of the actual process of swallowing. It happens very easily, but particularly after the sleeve gastrectomy, because there has been such increasing pressure inside the stomach, they may actually be conscious of the fact that the food is going down their food pipe. And that being conscious of that, they may interpret it as some discomfort or difficulty. So they need to be accustomed to this as well. So diet-wise, there are going to be some significant changes, some restrictions that come from us, obviously, and some regulations that they have to follow afterwards. Okay, now, what is the other big thing, Kemal? It's activity. How about activity? How active can I be? Well, our rule is you have to move. Movement is very, very important. So movement is not only okay, it is absolutely critical for their recovery. It will enhance recovery, but also it will minimize complications like blood clots or pneumonia or other things. So we want our patients to be up as soon as they are off anesthesia, right? Within 2 hours after surgery, we see them walking, and we want them to be doing the same. So with this, all the idea of, oh, I had surgery, so I have to stay in bed, is a big no-no, right? We want them to be up and about every half hour, every hour. We want them to walk. Obviously, when they are asleep at night, they are asleep. When they need to take a rest during the day, it's okay. But the default position is up and about, essentially, right? So movement is very, very important. Of course, there are limitations. Come on, we tell them, for instance, they cannot lift a certain amount of weight. Usually it's about 15 to 20 pounds for the first month. They cannot do exercises that involve the core abdominal muscles because there are wounds that are healing. But other activities like walking, like treadmill, like stationary bike, like elliptical, we want them to do that and to increase that as the days pass after the surgery.
Well, those are in terms of fitness. That's kind of like similar to any other general surgery. If I have like a gallbladder or appendix surgery, that I'm not going to be able to do certain things for a certain time.
Absolutely.
From the fitness standpoint, understanding walking is one of the most effective, most healthy for any patient, anyone. So it's not just patients with surgery. I think that's really important. So now we talk about that they will also need to take. We have a special topic session for the multivitamins, but they need to take those vitamins. Any other medication that they need to be taking?
Absolutely. I'm glad you brought up this issue of medications, Kemal, because there are going to be new medications that we want our patients to take after surgery, at least for a limited period of time. And there are going to be the issue of their old medications as well. Okay, so how do they do that? Well, let's talk about the new medications that we want them to take. Okay, all patients will be taking an anti-acid medication, right? This is something that reduces the acid in the stomach. Now, patients could be on an anti-acid medication before surgery, and obviously they continue with that if they have it. But if they didn't, we want them to start on this anti-acid medication, and this usually will be prescribed for them at their surgical clearance visit. Patients who still have their gallbladder, patients who never had gallbladder surgery, we will want them to take a medication called Orsodiol, which is a medication that actually decreases the risk of gallstones and gallbladder problems as they are losing weight fast. So one of the consequences of rapid weight loss is actually gallbladder problems. And this was such an issue in the past. You know, the surgeons who taught us bariatric surgery 25, 30 years ago, they used to actually take the gallbladder out routinely when they did weight loss surgery. We don't take the gallbladder out routinely now, but we give this medication, which reduces the risk of gallbladder problems from about 30% to about 3%. And of course, if patients have had their gallbladder out, they don't need to take this medication. Mm-hmm. Another medication, which is very important, not in every patient, but in patients on whom we think there is a higher risk for blood clots, is we send them home on blood thinning medication. This medication is generally taken for about 30 days, but it's an important addition to all the other precautions we take to decrease the risk of blood clots, which is a very, very important issue. Now, one thing that is very important to address, Kemal, is that in terms of medications, patients are actually allowed to take pills. In the past, we used to say you have to crush their medication, they have to take liquids, and that's not the case anymore. We actually have gone away from that idea. Patients can take pills, right? So if they had medications they were taking before, like blood pressure medications, diabetes medications, cholesterol medications, other medications, they can continue to take them. But there is a little caveat to that, Kemal, and that is if you had blood pressure before, if you had diabetes before, almost immediately as you start losing weight, your condition could be better. So the medication that you are taking could be either too strong for you or it may not be necessary. So patients, for instance, who've been taking high blood pressure medications, they may notice that they are becoming dizzy now after surgery, right? And that is because rapid weight loss is improving their blood pressure. So when they take blood pressure medication, their blood pressure actually goes too low. So those patients, we actually tell them, look, make sure you make an appointment with your primary care doctor very shortly after your bariatric surgery so adjustments can be made to your medication. This is great news, of course, because we want them to decrease their medications. We want them to be off those medications, but it needs to be done in a supervised manner, right, by following the guidelines with their primary care doctor. And the same is for diabetes medications. In some cases, patients may need to be off of the medication almost within the first few days after surgery. So checking their blood sugar and making sure that it's not going too far down is important. But in general, patients obviously need to continue their medications unless they have been told otherwise by us or by their primary.
So speaking of the follow-up care, you mentioned the PCP, primary care physician, but also our wellness program after bariatric surgery. We call it wellness because now patients are no longer suffering from morbid obesity, hopefully, as long as they're following the
Absolutely.
guidelines after the surgery. And, for someone to lose, let's say if they're like 325 pounds, and then in the first 8 months, maybe they will lose 80 pounds. That's a lot, right? So in order to do that, they have to really follow the doctor's orders.
Absolutely.
So
Absolutely.
no matter he is, so then you have to follow his orders. So if you are his messenger, then you can follow our orders. But I see in some cases patients feel better and then they're not following through with with what's given to them. This is a big life-changing event, and it's going to take time to get there and to make it permanent, to prepare our patients the best. They really need to follow through with the care that we are providing, because every time I see someone who's coming back for the weight regain, those are the ones who are not actually following through their appointments. So we just want to do stress that out. Now, speaking of stressing out, sleep and stress, how are we? How is that affecting us after surgery?
So generally, as patients are losing weight, actually their sleep gets better. They sleep better. They will almost all universally tell us that. And one particular group of patients who suffer from sleep apnea, for instance, they will find that with decreased weight, there is less of an impact of sleep apnea on them, so they have more restful nights. Of course, if these patients are on a CPAP machine, we want them to continue utilizing that CPAP machine until they have been told to stop, by their provider, whether it is us or the one who prescribed the CPAP machine to begin with. Now, stress is something different, right? It's something individual. Clearly, there is improvement in quality of life, right? As patients are shedding all that weight, as patients are recovering well from the surgery that they were anxious about, as patients are improving in their overall health, whether it's diabetes, high blood pressure, or others, they will become more satisfied with themselves, right? Their outlook will be better. There is no question about that. But we also know that bariatric surgery can bring about emotional changes that could be potentially stressful as well, right? There is this change, for instance, in the way they look at themselves, right? There is this rapid change and they may have difficulty recognizing themselves. And those physical changes can bring about changes in how they are perceived by their loved ones. For instance, there could be changes in relationship. For instance, a person who's losing weight could be feeling much more comfortable, much more self-confident, and that could be seen as a threat to their loved one in a way, because that could create insecurity. Of course. So all these issues are real issues, and we want patients to reach out when they really are faced with these problems and never think that they are things that just happen only to them, right? These are things that can happen, and we want them to articulate those things, to verbalize those things, to bring on these issues when they come up to follow up with us. So as you mentioned earlier on, although they're doing great physically, we want still them to follow up with us on those regular scheduled follow-up schedules that we have, so that they can talk about these things as well. So stress should be relieved after surgery because of all those improvements, but other issues can bring about stress as well, Kemal. And of course, there is life, right? Things could happen in life that can bring about stress and that could derail their progress as well. And so we want to make sure that patients know that we are there not just for their physical health, but also to provide support when they encounter challenges emotionally as well.
So, Dr. Earlier, I had our 2 p.m. event, and our state officials who joined us. And one of the things that I heard from them is working on different types of bills to make certain support in healthcare, certain extensions more available for those who may need them the most. So I think as I'm listening and as we work together, so what we realize is that this is not something that we are just gonna provide one part of the care. So this is like the entire team all together is working. Sometimes this team is not under one roof. They are different, like the patient's PCP is in a different place. We are in a different place. Our nutritionists, our social workers, our other specialists are all available. So as we spend more and more time with the patients, and I personally review minimum, I would say 15 to 20 charts every day, unique charts. The same issue that I see is follow-throughs, not actually getting what you need in a timely manner. And we are always, like even ourselves, guilty of this. So I'm not saying that we do this at the best, but if the problem is there, the only way that we can actually take care of this is by going through your appointments, making sure that you have dealt with this for the entire life, your entire life. Mm-hmm. And now it's not going to be fixed overnight. The surgery is the most effective way to fix it. But in order for that to be permanent and then the life transition to be healthier and more effective, you really need to follow through your instructions from our program. So this is why I can't emphasize enough. Every time I see a problem with a patient with a crisis is because they missed 2 appointments, but now they have a crisis. So we want to learn from what we have done in the past so that we are not repeating those mistakes. So then because it's just really, imagine this way, Dr. Ergau, like someone who's at 350 pounds, and then now they are 220 10 months later. That's one person that they lost, sure. Right? Sure. And then that's a huge change. Yep. And it cannot be that easy. Obviously, nothing in life is easy. Mm-hmm. For example, I still didn't eat today because I'm doing the intermittent fasting. So I walked for 3 miles when I had a break in between. And I have to force myself to do it. It's not like, oh, let me just go and then walk. I'm just like, I can wait until next time I walk. No, like it takes some push. And sometimes we're able to do this on our own. And sometimes we're not. And when you are not, we are there for you. So then we are willing to work with you and make this journey as successful as possible. Anything we missed, Dr. Ergau, with this?
No. First of all, let me just comment, Kemal, that I was very happy to see that you're continuing to engage, our political representatives here in Delaware on health issues, and I'm happy to see Melissa Minor-Brown and Sarah McBride in your show today, talking about health issues that are so important to our community. And this brings me back to what you said earlier on, and that is it takes a village really to bring about changes, even on a single individual, Kemal. It cannot be in a disconnected fashion. That's why the care coordination, that's why the understanding about social determinants of health is so critically important, because all those issues are relevant in determining how well we are doing when we apply treatments, right? So gone are the days in which we relied just on one doctor to fix things in a patient, right? We have to really act as a society looking at all the angles. And the more mature organizations we have, like ours, networking all these different providers and also reaching out to people who can impact, legislations and interventions that will improve the well-being of our community, the easier our job is going to be. And this is no better represented than when we look at a disease like obesity, Kemal, because there are so many determinants to it. And similarly, although we are providing important tools like bariatric surgery, we need other things to be in place for this to be successful completely. And this, obviously, we talk a lot to our patients. And then going back to issues that we may not have addressed when we talk about what to expect after bariatric surgery, Kemal, we've covered most things that are relevant, but obviously critically important is the fact that patients need to follow up with us, right? And we tell patients also to make sure they call us whenever they feel they are not progressing in any way early in their recovery, because that could be a sign of a complication. So if they have a fever, if they're having repeated episodes of nausea and vomiting, abdominal pain, all things like that are thankfully not very common, but it's important for them to reach out because that could be a sign of a serious complication. And obviously we need to be there to help them out. Other issues that can occur, after surgery, they can notice fatigue, for instance. That is not uncommon. Patients may notice that they are having intolerance to certain foods, and we talked about that. Patients may notice that they're getting cold very easily, right? That's actually an outcome of their weight loss, because fat is an insulator, and they're losing fat. Essentially, they may feel colder. They may notice hair thinning, for instance, particularly between the 3rd and the 6th months after surgery. Some patients may experience acid reflux symptoms, particularly after the sleeve gastrectomy. Bowel habit changes like constipation can occur as well, or something called dumping syndrome could occur, particularly after gastric bypass surgery. So all these issues can occur, Kemal, but as I said, and as you mentioned also, regular follow-up with us, 2 weeks after surgery, 1 month after surgery, 3 months, 6 months, 9 months, 12 months after surgery is our regular follow-up schedule. Is very important for us to be able to address any issues that they may have afterwards.
So, Dr. Ergau, the way, let's see how much this makes sense. So sometimes maybe as a person, we underestimate the importance of being able to talk to someone about a problem that we are having, not maybe at the time of the problem, but after the fact. So the reason I say this is because when I follow up with some of our patients on the accountable care organization side, as well as the bariatric side, when there's an unhappy patient, these days, after 8 p.m., I call the patient. And sometimes, with our process before they get to surgery, I call them. But on the other side, with the non-surgical patients, when they hear from someone, that makes a big difference. And already the tone is changing, so they feel already better. So I don't remember any patients yelling at me on the phone just because I reach out to them, either follow up on something that they were asking, or they were unhappy because they weren't able to get someone on the phone. So my point is, what we know just from the experience is when you are going through difficulties, having people listening to you has a huge impact in the overall well-being. So these follow-ups are part of that. So even if you don't have anything going on, if you see the nutritionist on a regular basis, just because you may be going through the process a little bit slower, so then that conversation does have an impact on what's happening.
Absolutely.
So the conversation that you may have with your primary care has an impact on how you are feeling. Maybe you have some issues to access to food, or maybe some financial problems. So our social worker can be part of that conversation. Even sometimes they help us with their conversation, because we're like, oh, we didn't know that this was available to the patients. So this is all about the entire program altogether, to make sure that it's hitting every spot to make sure that this is successful, because we don't want patient to come back 2 years later saying that, oh, this didn't work. Yep. It always works. The only time it doesn't work when we are not following the standard instructions and then staying with the program. So that's kind of like the key that I feel that we need to follow.
Absolutely.
All right. Well, Dr. Ergau, thank you so much again.
Thank you. Well, it's great to be back on Bariatric Friday as usual.
Absolutely. It's great to have you back. So we'll be back next week. It's Halloween on Monday. So don't eat too much candies, too many candies, or just give out the candies. People are bothering you. But until next week, please stay safe and happy Halloween. Bye-bye.
Take care, everybody. Have a nice